Last year, I had hyperpigmentation on my face for the first time, and I did not know what to do about it. But like every other Gen Z kid with a problem and a phone, I wasn't gonna call my mom or speak to a dermatologist. I took a picture and I uploaded it to AI. I mean, why not, you guys? It's 2026, and AI is literally everywhere right now, doing complex, amazing things. So surely it can tell me how to clear up some dark spots on my face, no big deal. I upload this photo right here to AI, and I ask a simple question: what is this on my face? Now, I was not expecting what it said next. With clear confidence that makes you think that it knows exactly what it's talking about, my AI said, this appears to be vitiligo. Vitiligo, hello? I mean, hear me out. I know better than to be asking a chatbot these questions, I really do. But in that moment, I kind of spiraled a little bit because if an AI that was trained on probably millions of images could look at my hyperpigmentation and call it vitiligo, what could be missing, right? Good evening, everyone. My name is Tomisin Adebari. I'm a Morgan alum, and I'm currently doing my master's in Johns Hopkins, doing my master's in biomedical engineering. I want to become a physician engineer someday to make medicine more innovative and equitable. And this little chat that I had with AI kind of put me in a rabbit hole that I have yet to come out of. I started asking questions, the simple ones, the broad ones. Like, what kind of data are we training our models on? Where does this data come from? Who is included, and what does it look like? I work with data, lots of data. I work with data, lots of data. And the moment you start to see the patterns behind healthcare data, you really cannot unsee it. But AI in healthcare is growing really fast, you guys. Just last month, OpenAI launched ChatGPT for Health. It's going to be rolling out to major institutions like Stanford Medicine and the likes. According to them, over 230 million users ask ChatGPT health and wellness question every single week. Well, guilty as charged. Also, last month, Utah became the first state to allow AI prescribe medications autonomously. So AI is probably in the hospitals right now helping doctors decide treatment plans, reading our x-ray data, or even getting to decide who gets extra care. And I love all of this. I love the hype. I think the potential here is very incredible. But let's take a step back first and think about all of this AI. The keyword here, actually, machine learning, is quite interesting. You take data, tons of data, you feed it into this algorithm, and it learns to read what it's seeing. Patient data, healthcare data, all of this. And it makes predictions, right? But technically, you could say AI works like a mirror. It reflects us back to ourselves, our data, our patterns, our keyword here, history. But unlike any ordinary or fancy mirror out there, this is a mirror that learns fast, faster than we'll ever do. And it amplifies whatever we give to it and tries to convince us that what it's showing us is the objective truth. Let that sink in for a moment. But let's also talk about, how does bias arise in healthcare data or AI? What does it look like in practice? I'll paint you a very interesting picture. You're at the hospital, COVID probably, and there's this little clip thing on your finger, the pulse oximeters. It says that your oxygen levels is like 95, 96%. So technically, you're good, you're fine. Well, except if you're a black person, there's an 11.7% chance that that number could be lying to you. And technically, your blood levels could be low, even dangerously low, and nobody would know anything. Now, these devices are used everywhere across hospitals all over the country. And a researcher was interested in this in a particular state. It was looking at 7 years' worth of data for veterans. They found out that this has happened approximately 573,000 times for black veterans. In a specific word, that number haunts him. It haunts me too. But you might be saying, Tommy, what are you talking about? Pulse oximeters are not AI. They're medical devices. Yes, I agree. However, they're a source of data. Matter of fact, some researchers were asking this question: what happens when we feed these data readings that we get from the oximeters into a machine learning algorithm? The predictions were predictable, actually. Their results were predictable. For Black patients specifically, the predictions of the AI plummeted. Now, biosensors readings are only half of the story. The data that we're trying to train the future of healthcare on is being pulled from a system that many people have long been excluded and exploited. From the ethical violations of the Tuskegee syphilis experiment to the unauthorized use of Henrietta Lacks cells, many times history has given many communities of color every reason to look at clinical research with a guarded eye. This legacy of mistrust in healthcare has created a massive representation gap in our data. According to the FDA in 2020, the average clinical trial is nearly 75% white participants, and Black participants make up like less than 8%. And even more shockingly, 1/5 of all clinical trials proceeded with 0 Black participants. It's quite simple. When we're excluded from these trials, we're excluded from the data. And when we're excluded from the data, we're invisible to the technology that was built based off this data. Now, let's talk about resource allocation and off of treatment. A science study in 2019 was looking at a particular algorithm that served over 200 million people all across the country. It was used to determine who needs extra care and support. But this algorithm was linking spending to healthcare, to health and wellness. But technically, Black patients spend less even when they have the same conditions. So the AI was recommending less Black patients for care. And when researchers tried to fix this error, the numbers of Black patients that were recommended for care tripled from about 18% to 47%. We've seen with all of this that when we don't stop and start to think and look at the content of our data, the people that are included in data, and all of this, our history, we're, like what my friends would say, cooked. Because AI is powerful. It's very powerful. And like my favorite superhero, Spider-Man, famously quoted, with great power comes great responsibility. But what happens when that responsibility fails? What happens when an AI system that was designed to make people feel better works for some and works against some people? Where does that responsibility fall? Is it the patient's fault for having a different skin tone or being from a different race? Or is it the doctor's fault for trusting the algorithm? Or maybe it's the engineer's fault for building the algorithm in the first place. We cannot build universal tools based off of non-universal data. When we do, we shift the burden of safety onto the people that the algorithm was never designed for. You guys, I'm not here to give us all gloom and doom. I think raising awareness is always an important thing. Now, we're at a risk of automating the fragility that already exists in our healthcare system to a larger scale with the way AI is growing. But sometimes all it takes is just a little bit of intentionality on our part, a little bit of intentionality in our construction, and which really starts right from data collection, and it includes all of us. So whether you're building AI or maybe using it in practice, or maybe you just want to stay healthy, I think it's important to think about everything that I have said so far. I think, and I'm hopeful, I'm really hopeful, well, not because I eventually saw a dermatologist and she told me it wasn't vitiligo. We're at a turning point here. The potential is very real, and we get to decide what happens next. We don't have to be superheroes to do any of that. AI in healthcare AI is going to change healthcare, you guys, and I'm here for it. But are we intentional enough to make sure that at the end of the day, that nobody is left invincible? Thank you.